SimCMU judges, thank you for allowing me to present my research entitled Lordotic versus non-lordotic cages in minimally invasive transforaminal lumbar interbody fusion for sagittal balance correction, patient-reported outcomes, longitudinal cohort study. My name is Michael Lawless. I'm a fourth-year neurosurgery resident at Ascension Providence Hospital. I have no relevant disclosures and will not be discussing the off-label use of medical devices. Lumbar fusion is a workhorse approach for treatment of a variety of degenerative conditions, including spondylolisthesis, recurrent disc herniation, synovial cysts with instability, to name a few. The surgeries were traditionally done using an open technique involving large incisions and extensive muscle dissection. However, newer minimally invasive techniques, often through tubular dilators only as large as 22 millimeters in diameter, have become increasingly popular due to smaller incisions, less tissue disruption leading to shorter hospitalizations, and faster recovery. In regards to the biomechanics of the spine, there's the concept of the postural cone of economy, first introduced by Jean Dubuisset, further refined by Lafage and colleagues, demonstrating that pelvic incidence matching the lumbar lordosis and decreased tilt of the pelvis directly correlated to improved patient-reported quality of life measures in scoliosis surgery. With an ever-increasing focus on and expectation for improved quality in spinal surgery, there has been more recent interest in applying these concepts of sagittal balance to smaller 1 to 2 level lumbar fusions to yield the best patient outcome. Minimally invasive fusions have inherent limitations on sagittal correction given the small working corridor. To combat this, numerous interbody devices or cages have been developed and designed to increase lumbar lordosis through expandable or lordotic shape of the device. Our goal was to compare the radiographic and clinical outcomes in patients undergoing 1 or 2 level minimally invasive fusion using a static or non-expandable lordotic and non-lordotic titanium cage. We retrospectively reviewed consecutive patients who underwent 1 to 2 level fusion from 2017 to 2019 at a single institution with multiple surgeons. Standing radiographs were obtained at the preoperative, 1-month, and 6-month postoperative visits. Patient-reported outcomes were prospectively collected at preoperative, 6-month, and 12-month postoperative visits. Univariate analyses were used to compare lordotic and non-lordotic cohorts. P-value of less than 0.05 was used for cutoff for significance. You can see here in the patient demographics, we identified 84 patients from 2017 to 2019 meeting our study criteria. There were 32 patients in the lordotic cohort and 52 in the non-lordotic cohort. As you can see, there was a statistically significant difference in age between the two groups. And in the surgical indications, where there was higher rate of indication with disc herniation in the lordotic group versus the non-lordotic group. The two cohorts were otherwise homogeneous. For our radiographic analysis, standing lateral x-rays were obtained. There were no significant differences at the baseline parameters. As you can see, these include the lumbar lordosis. At the 1-month follow-up, there were no significant differences between the groups. However, at the 6-month interval, you can see the change in lumbar lordosis neared significance in the lordotic group, with an improvement of 3 degrees compared to the non-lordotic group with a loss of 0.08 degrees. However, the p-value was 0.06. When assessing clinical outcomes between the groups, both groups had improvements in all pain and quality of life scores from the preoperative to postoperative visits. The lordotic group did have a significantly greater improvement in the VALS leg score, which is a surrogate for leg pain, at -7 points compared to the non-lordotic at -4.3 points. To further characterize this, relationship between leg pain and radiographic parameters, we used Pearson's correlation However, we found no significant correlations between any of the radiographic parameters and leg pain. We did find a fair degree of relationship between VAS leg and lumbar lordosis, correlation coefficient of negative 0.264, as demonstrated in the scatter plots here. In conclusion, the use of minimally invasive lordotic interbody devices and 1 or 2 level minimally invasive fusions trended towards improved lumbar lordosis and had significantly greater improvement in VAS leg at 12 months postoperatively. Continued patient recruitment is indicated given our near significant trends. 1 to 2 level minimally invasive fusion resulted in improved pain and quality of life scores in the study population, and these results were durable at 1 year. Further prospective randomized controlled trials are warranted. I'd like to acknowledge the St. John Providence Hospital IRB, Dr. Jackson and Dr. Flynn, for the support of our research. I'd also like to acknowledge Mr. Matthew Bahura and Ms. Madeline Fugate for assistance with statistical analyses, the CNE for supporting resident research during these unprecedented times.